Hello and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bower, the editor of GP Online. Today on the podcast I'm joined by our deputy editor Nick Bostock.
Hello.
And our senior news reporter Kimberley Hackett.
Hi everyone.
To talk about some of the latest news stories affecting general practice. Coming up today, we'll be talking about this week's budget and what that might mean for general practice and the NHS more widely. We're also looking at the GP workforce in England after latest figures show it has risen to a 5-year high despite an ongoing jobs crisis that has left many GPs struggling to find work. And we're discussing what's happening with the GP additional roles reimbursement scheme jobs that were due to start in October and why the RCGP is calling for a complete overhaul of the NHS long-term workforce plan. So we're going to come on to talk about the budget and what it could mean for the NHS and general practice a bit later. But first up, let's talk about the GP workforce. Nick, we talk about the GP workforce on the podcast quite a lot, actually, and it's usually quite bad news we're discussing. But for once, we have a positive story. What's it all about?
There are three main things we tend to look at when we're talking about the GP workforce. The number of fully qualified full-time equivalent or FTE GPs. So that's how many GPs there are when you factor in each individual GP's working time commitment. Then there's the headcount number, the actual number of fully qualified GPs there are in the workforce, irrespective of how many sessions they're contracted to work. And there's also the ratio of patients to GPs, which we usually represent in terms of how many patients per full-time equivalent GP there are in the country. And on all three of those measures, there are positive signs in the latest GP workforce figures, which are for September this year. The headcount figure has actually risen to the highest point we've seen since September 2015. So that's going back to the earliest point that we have comparable figures for. There are now just over 38,000 fully qualified GPs in England, according to these figures, which is about 2,000 more than there were in 2015. Rises in the headcount figure, though, don't always translate into an increase in full-time equivalent numbers because there's been a trend towards GPs working fewer sessions. We've talked before about the fact that the way these figures are calculated doesn't properly reflect the actual working hours GPs are putting in. So these figures aren't perfect, but they still offer a picture of how things are changing over time. And actually, the full-time equivalent GP workforce this September is higher than any previous September since 2019. So the workforce basically at a 5-year high. Fully qualified FTE GPs have gone up by more than 600 just in the past year. So that's a really positive bit of news after a long time in which we've reported on steady declines. And then on patients per GP, there are now 2,273 patients per GP across England. That's a lot. It's still about 25% higher than the figure some GPs talk about as the safe limit, which is 1,800 patients per GP. But that figure has come down over the past year from a high of just above 2,300. So it may finally be moving in the right direction, which is positive.
Do we think the GP workforce is starting to stabilise? Are we turning a corner? Is that what these figures are suggesting?
GP leaders have said these figures are encouraging. And as we've said, they offer a different picture from the constant decline we've been reporting on for nearly a decade now. But there are some big caveats we should add. And I think it's probably a bit early for anybody to be popping champagne corks. As I touched on just now, the number of patients per GP is still incredibly high. It's come down a bit, but it's still very close to an all-time high. And if that's where the average is, as we know, in parts of the country, things are much, much worse. There are under-doctored areas where the numbers of patients each GP is responsible for are far higher. So although this figure's moved a bit in the right direction, general practice needs a lot more movement to get to a position where the number of patients per GP is safe. By 2040, the BMA has said it wants to see the profession move closer to a ratio of 1,000 patients per fully qualified full-time equivalent GP. That's about a third of the current level. So to get towards that figure, with the population going up, means a steady flow of lots more GPs over a really prolonged period. It also means doing a lot better at retaining the ones we have. All of that means funding, in particular funding to make sure GP practices can actually afford to hire more GPs. We're going to come on to talk about this a bit more shortly, but we've reported a lot over the past year or so on the fact that thousands of GPs are currently struggling to find work, despite the fact that practices are facing record demand. We've talked about GPs working as Uber drivers, working for Tesco, moving abroad, and all kinds of absolutely shocking examples of the ways we're losing GPs. Amanda Doyle, GP who is NHS England's Director for Primary Care and Community Services, admitted recently that although the health service had pushed up the numbers of GP training places significantly in recent years, it simply hadn't provided the money needed to give practices the capacity to hire those doctors. GP ARS jobs are a start on that front, but more core funding to drive up the numbers of GPs practices can afford to bring in is crucial.
That's an interesting thing about GP training. I suppose the big question is whether what we're seeing here is the result of that significant increase in GP training places in recent years. We're going to come on to talk about retention. You touched on that there. We're going to come on to talk about that and what the RCGP has got to say about that. But, surveys from the college and the BMA suggest retention of GPs across their careers is still a real problem.
Yeah, I think these workforce figures do reflect the higher numbers of GPs coming through training. The latest workforce figures show there are about twice as many GP registrars in practices now than there were in 2015. So numbers of doctors choosing to train as GPs are really moving in the right direction. And this has happened because for the past few years, there have been about 4,000 GP training posts in England each year, compared with about 2,500 a decade ago. And these larger cohorts of GP registrars are now qualifying. So the UK system is turning out more GPs each year than ever before. But we know from BMA polling, which you mentioned, that many registrars don't expect to work in UK general practice at all. And we know from RCGP polling that many existing GPs don't expect to remain in the workforce for much longer. So creating opportunities for new GPs, keeping existing ones, are massive challenges that need to be addressed. The RCGP's put out proposals on how to do this, and you mentioned we're going to come on to this a bit later. So there are proposals out there to boost retention. General practice just needs the government and NHS England to listen and pick up the baton on some of these.
So the overall GP workforce is increased, really positive news, but the picture isn't that great for GP partners, is it? What does the data show about that?
Partners are another big reason why no one should really be celebrating the GP workforce data just yet. Just to put the numbers in context, overall, fully qualified FTE GPs are down by about 5% since 2015, despite the rise we've seen more recently. But FTE GP partners are down by about 27% compared with 2015 and have fallen by about 3% just in the last year. So that's a trend that's still moving very much in the wrong direction. It probably reflects the move to larger practices, practice closures up to a point, but also the fact that, as we've mentioned, the NHS just isn't retaining GPs very well. So lots of experienced GPs who have been in partnership roles are leaving.
Yeah, Kimberley, let's bring you in here. Nick mentioned the current GP jobs crisis earlier and some of the stories we've run in the past about GPs working for Tesco's and Uber. But we actually ran a fairly shocking story last week, which suggests this is still very much a problem, didn't we?
Yeah, we did. So this story is about a newly qualified GP who signed up to Universal Credit because they were unable to find work. The GP's dad called into Jeremy Vine's BBC Two radio show as part of a Q&A segment with the Health and Social Care Secretary Wes Streeting. The caller, called Bob, said that his son had qualified as a GP in August, and when he went into the job centre to sign on, staff were flabbergasted when they found out what his job was. But that's not all. Bob also said that some of his son's friends were failing their GP exams deliberately so they could stay in their GP registrar jobs for as long as possible because they were so worried they would be unable to find work as a GP once qualified. Now, Wes Streeting did express his frustration and said he hopes the ARRS GP expansion that will allow for the employment of 1,000 more GPs will help. But the Health Secretary did admit that it will not fix everything, but he sees it as a good start. And the RCGP said they hadn't heard of registrars deliberately failing their exams to stay in work, but they did say they would support anyone considering this type of action.
Yeah, Nick, I mean, as Kimberley mentioned there, one of the hopes of addressing this problem is the new GP ARRS jobs, which we spoke about on the podcast a couple of weeks ago, didn't we? The BMA put out some guidance about how these roles should work during the past couple of weeks. What did they have to say?
The guidance is an 8-point list that essentially applies existing BMA policy on various aspects of employment to the ARRS GP roles. On pay and conditions, it calls for ARS GPs to be employed on the BMA salaried GP model contract, for example, to make sure their terms and conditions are in line with BMA expectations. It calls for salaries to be in line with the BMA's recommended salary GP pay range, and for these doctors to be guaranteed access to the NHS pension scheme. The guidance also calls for a job plan that builds in safe working guidance. 15-minute appointments as standard, a limit of 25 appointments per day. These are measures GP practices are adopting as part of collective action at the moment, but the BMA has been pushing for some time for these safe working limits to be incorporated into all salary GP contracts. The list also calls for ARS GPs to be offered support from a mentor, only to work in core hours to make sure they're fully supported by more experienced colleagues, and for the number of practices these roles are split across to be no more than 2. These points about safe working and support go to the heart of concerns about the way these roles are set up. There's been a concern that newly qualified GPs taking on these roles won't get the support and guidance that they might receive if they were working at a single GP practice, and that the benefits ultimately of continuity, both for them and for the patients, could be lost. And then finally, the BMA wants a plan to transition these roles into practice-based employment at the end of the current ARRS GP job plan, which runs only to the end of March next year. The government has promised that funding is going to continue, but we've yet to see any detail on exactly how that's going to shape up.
Kimberley, you've been keeping an eye on these GP ARRS jobs. What do we know about how this is all going? I mean, is there interest in these roles from GPs? Are PCNs getting lots of applications? And what do the actual jobs that are on offer look like?
So some PCNs have told me that there have been a high number of applications for the ARRS GP roles, which doesn't really come as a surprise given we know that GPs are struggling to find work at the moment. One company that is hiring on behalf of PCNs said they had 12 applications a day, which they said was more than usual. Despite many of the adverts not going live until mid-October, we do know that a GP was recruited through the ARRS this week and will start work next week at a PCN in Wiltshire, and it is thought that they are the first doctor to be recruited through the scheme. While details of that GP's job have yet to be revealed, I have looked through 41 ARRS GP job adverts from across England to see how the roles compare. Most are advertising part-time or full-time fixed-term contracts ranging from 4 to 6 months. And while we know that funding for the scheme will continue beyond the initial 6 months, there hasn't been any confirmation as to how much money will be available and for how long. Because of this, many PCNs have included lines in their adverts saying that the contracts could be extended. But there have been a few practices that have advertised longer contracts. One PCN in Hertfordshire has advertised the role on a part-time basis for a 12-month contract, while another PCN in southwest London is offering a permanent contract for a GP to do 3 hours a month to help with chronic disease and medication management. The only other permanent contract offer I saw was from a PCN in Peterborough. The successful candidate will be expected to work full-time, doing 8 sessions a week and earning a salary of £9,000 per session. From what I could see, most PCNs were offering salaries just below or towards the lower end of the BMA salary paid range suggestion from £82,225 to £120,444. And as Nick mentioned earlier on, the BMA has suggested that ARRS GPs should only work across a maximum of 2 practices, but this hasn't been the case across many of the adverts that I saw. One PCN in Manchester said the role will cover 11 practices, doing 5 sessions a week. Another PCN in Lancashire said the GP will work across 6 practices, doing 4 or 5 sessions a week. But a Leicester PCN was the only one that I came across that wants an ARRS GP for each of the 3 practices it covers, When I spoke with one of its GPs, Dr. Grant Ingrams, he said he thinks it would be stupid to employ one GP to work across 3 sites because it means they would have to travel long distances between each other. What is interesting is that he said that with the funding available, the PCN will only be able to claim just over £8,000 per session, but the practice will top up the salary from anywhere between £9,500 to £10,500, depending on a candidate's experience. And as Nick said earlier, the BMA has urged employers to ensure ARRS GPs do 15-minute appointments and no more than 25 patient consultations a day. But across the 41 adverts I saw, none of the PCNs outline this.
As Kimberley says, it looks like many of these jobs aren't in line with what the BMA wants to see from ARRS GP roles. Many of them are spread across more practices or locations than the BMA would like. The rates of pay are sometimes lower than the BMA has recommended, which may reflect the funding available to PCNs. And there's no sign of safe working advice being incorporated into the job specs. I guess on that point, there may be a chance that if practices that these doctors work in are already adopting safe working advice, either prior to collective action or as part of collective action, and many are, perhaps that could be a feature of how they work in the end anyway. But overall, I think these job ads Kimberley's been working through won't provide the kind of reassurances the BMA and others would like to see about the kinds of jobs that newly qualified GPs are going to be going into through the ARRS.
The other big workforce story we ran last week was about a new RCGP report that called for the government to overhaul the NHS workforce plan and put together a new strategy for GP retention. Otherwise, it says thousands of GPs could be lost to the NHS. You were looking at this, Nick. I think we've spoken on the podcast in the past about the RCGP's objections to the NHS long-term workforce plan. And certainly the college chair, Professor Camilla Hawthorne, mentioned this when she was on the podcast a few weeks ago. But just remind everyone, why is the college so unhappy with the workforce plan?
So, the college said earlier this year that the government needs to break the cycle of training more and more GPs and watching them leave. I mentioned earlier that the rise in doctors coming through GP training in the UK, but the RCGP says that thousands of these qualified GPs are going to be lost to the NHS unless the government revisits the workforce plan, which it inherited from the previous administration. Essentially, the college says the plan's built on unrealistic assumptions, contains too much uncertainty, and it wants a comprehensive review of these plans to focus much more, in particular, on retaining GPs. One of the big concerns the college has flagged is a report from the National Audit Office earlier this year, which warned that the NHS workforce plan was built on the substitution of GPs with other staff, essentially through a massive expansion of the multidisciplinary team without really growing GP numbers. We reported on that at the time, and the NAO said the workforce plan projected only 4% growth in the fully qualified GP workforce by 2037, while hospital consultants would increase by 49% over the same period, so 12 times faster than the GP workforce. Part of the problem with that, as we've spoken about a lot in the debate around physician associates, is that other staff can take on some elements of GP work, but they need supervision and oversight from GPs. It isn't simply about stripping work away from GPs. GP numbers actually need to grow much faster too. Recent polling by the college found that 42% of GPs expected to leave the profession within 5 years, with many citing stress and burnout and plans to move overseas to work. So the college wants more support for GPs and better plans to retain them in the UK workforce, like I said, to break this cycle of training doctors, watching them leave, whether that's to move abroad, retire early, or leave the profession altogether.
Yeah, it's actually interesting, isn't it? Wes Streeting was at the RCGP annual conference at the start of October, and Camilla Hawthorne, actually, while he was on stage, she actually asked him about this. She mentioned the workforce plan, about the fact they were not happy with the projections for how the GP workforce was going to grow compared with hospital consultants. And obviously she put it to him, it wasn't going to necessarily help him with his plans to move more care out of hospitals and into the community. And he did actually say that in light of that, and in light of what the Darcy report had found, which we talked about on the podcast before, that he was potentially quite open to re-looking at some of those numbers. So I think the college is probably pushing a bit of an open door in terms of a review of those figures from this current government. The RCGP report that you talked about there, Nick, it also called for a national retention strategy for general practice with ring-fenced funding. And we know this is something that the college has been calling for a while, hasn't it? I mean, it was part of the college's manifesto, which it published just over a year ago. So this new report, which is called Retention, Looking After the GPs of Today to Safeguard the Workforce of Tomorrow, it's got much more detail on what the college actually wants to see happen in terms of GP retention. And the college says that this report is a call for action for policymakers and healthcare leaders to get them to collaborate to really grasp and deal with this GP retention crisis. And it says that putting in place an active and bold plan, as it calls it, to improve GP retention is one of the biggest single steps the NHS could take to deliver rapid improvements in general practice's ability to meet growing patient needs. So what exactly does the college want this retention strategy to include? Firstly, the RCGP says that NHS England needs to reintroduce the fellowship programme for new GPs and the supporting mentor scheme for more experienced doctors, which we've talked about on the podcast a lot and which were both scrapped last year. It also wants more sustainable funding for programmes that have been shown to improve the experiences of GPs and help boost retention. And, programmes that get a mention in that report are the Phoenix programme and Wise GP. And we've actually had people on the podcast in the past from both of those initiatives. It also says NHS England should appoint a local GP retention lead for each integrated care board and develop a platform for sharing best practice on how to retain GPs across England. And it wants protected learning time built into the GP contract and for NHS England to guarantee future funding for NHS practitioner health. There's still some question marks over the long-term funding for that service. And finally, it says the problems around visas for newly qualified GPs who are international medical graduates also need to be addressed. So there's a lot of concrete ideas and measures there that the government and NHS England could take on. They're quite thought through, some of those things. And if they did take those ideas on, they could really start to make headway and start to grapple with this issue about GP retention. Moving on, let's talk about the budget. So firstly, let's perhaps look at what the budget had to say about the NHS as a whole, and then we'll come on to look at some of the measures that are going to have a particular impact on GP practices and what some of that might mean. So firstly, NHS funding. It was quite good news, really, there. Chancellor Rachel Reeves announced the government would provide an extra £22.6 billion in spending in 2025-26 compared with what was spent in 2023-24 for the Department of Health. So this represents an average real terms annual increase of 4%, the government says, but other analysts, since the actual budget came out, put that figure at about 3.8% increase, as real terms increase. The Chancellor said that this would help the NHS in England deliver an extra 40,000 elective appointments a week. That was a key manifesto pledge. And over the long term, obviously, the aim is to make progress towards getting waiting lists down to 18 weeks eventually. But that's obviously an absolutely mammoth task. I guess for a bit of context, the government says this is the biggest increase in NHS spending since 2010, excluding those pandemic years. Their Health Foundation think tank says that a 3.8% increase is similar to the historic average increase the NHS has received. And the King's Fund said that this level of an increase would help sustain services, but that it was unlikely to drastically improve care over the rest of the year. It might be worth mentioning an analysis by the Health Foundation earlier this year that said that to achieve really sustained improvements to the NHS, it would need annual real terms funding growth of 3.8% over the next 10 years. But the Health Foundation suggested that that would really need to be quite front-loaded. So it was saying you needed to see a 4.5% increase in funding in the first 5 years and then lower rates of growth in the second 5 years. So obviously this 3.8% is lower than what it would have liked to have seen in the first 5 years. So in addition to that day-to-day funding, Rachel Reeves also promised extra capital investment that will amount to £3.1 billion in 2025-26. Some of that, this is quite good news for GPs, some of that will be used to establish a dedicated fund to deliver around 200 upgrades to GP surgeries that's worth £100 million. There's not really any detail of how that will work or who will qualify for the funding yet. But the government says this will support improved use of existing buildings and space, which it says will help boost productivity and enable practices to deliver more appointments. In terms of other capital investment, lots of money around for things like new surgical hubs, diagnostic scanners and extra beds to build capacity, money to address the rack concrete problem in hospitals, and also money to address the backlog of estates problems in hospitals, £2 billion for technology and digital improvements to help increase productivity, including money to make the NHS app more effective for people to access the health service. The government is expecting the NHS to deliver a 2% increase in productivity for that funding, and also money to strengthen the UK's pandemic preparedness and to set up new mental health crisis centres to help reduce pressure on A&E. Rachel Reeves says that in exchange for all of that investment, the NHS will need to reform, and the 10-year plan next spring will set out how the NHS needs to change. And the Chancellor again mentioned those 3 key themes that will underpin how the NHS needs to change. So this is the move from hospital to community, analogue to digital, and treatment to prevention. And I think we're all going to be hearing those 3 things a lot over the next 6 months or so. What is interesting, perhaps worth mentioning about that, particularly hospital community, is that the budget document specifically says that the government wants to see more care delivered through neighbourhood health services. So that's, as I say, that move from hospital community, which the government says will provide more personalised care and deliver better value for taxpayers. It says that the idea is to reform delivery of elective care and patient care pathways to shift to what it calls lower cost settings wherever appropriate. And that suggests the government is really banking, I think, on the fact that it's cheaper to deliver care in community settings. And I'm not sure that is always the case when you're talking about particular procedures or types of care. So I think they do see this move to community as a way to deliver care more cheaply, but I'm not sure how they've made that assumption.
There's a lot in the budget that GP practices are going to be really worried about as well, isn't there?
Yes, lots of things in the budget that are going to have big impact on GP practices as employers. Firstly, the government's confirmed the national minimum wage for those aged over 21 will rise by 6.7% from April to £12.21 an hour. There's a 16.3% increase in the minimum wage for 18 to 20-year-olds. And that rise comes on the back of an almost 10% increase in the minimum wage this year and a similar rise in April 2023. The really big concern, I think, for practices will be the announcement of a 1.2 percentage point increase to employer national insurance contributions. So they are going to increase from 13.8% to 15% from April next year. The government's also reducing the threshold salary where employers become liable to pay national insurance, so from £9,100 down to £5,000. The government did announce a change to the employment allowance to soften the blow a bit for small businesses. That sort of increases the relief they receive on national insurance contributions. But accountants have warned that GP practices and other primary care providers are not currently eligible to claim for this. So that's obviously quite bad news. Clearly, it's a good thing that the national minimum wage is rising in terms of ensuring people are paid a decent wage. But if there's no extra funding to cover this and all the rises in national insurance contributions, then they're going to have a huge impact on practices. I think, staff are far and away the biggest expense GP practices have. So any change on the cost of employing people is going to be a real cause of concern for practices. Before the budget, the BMA warned that any unfunded increases in employer national insurance contributions would pile extra pressure on practices and could basically fuel a wave of practice closures. GP contract negotiations between the government and the BMA will obviously be discussing how much money practices will receive from next April. And I'm sure covering the cost of this will now also be part of those discussions. The other thing to remember is obviously that employer national insurance contribution increase will also apply to ARRS staff. Presumably, the reimbursement rates that practices and PCNs can claim for those will increase to cover that. But what we also need to make sure happens is that the actual overall pot of money that's available for the ARRS, that increases to reflect it as well, because the last time those reimbursement rates increases, that didn't happen. And so any PCN who was almost at the limit of how much they could spend were unable to actually pay their staff anymore because the overall pot hadn't increased. So basically, there is a lot of concern here for GPs.
I've been looking at the reaction to the budget from the BMA and RCGP and from accountants and so on. I think the sense overall, as you've said, is that this budget has loaded extra expenses onto practices, whether it's from national insurance or the minimum wage, for example, without explaining how or whether they'll receive any additional support to cover those costs. And that really is a poor message for practices at a time when many are already struggling financially. Uncertainty over the financial situation for the year ahead is just really not what they need. The BMA pointed out that it had called just recently for a £40 per patient increase in funding for practices from next year. It's a substantial rise. And then instead of any comment on that, any sense of a concrete plan for general practice had been glaringly absent in the message that came from the Chancellor, Rachel Reeves. Accountants, the BMA, and also organisations like the Institute of General Practice Management have all said that the government now needs to come out urgently and offer some reassurance to practices over how this is going to work. Overall, there's a sense of encouragement from the overall uplift to the NHS budget and from things like the promise that you mentioned to invest in GP premises. But at this point, GPs need clarity about how they're going to be supported to cover these really significant cost implications that the budget has for practices. I think the key message is that practices can't be expected to wait until the next contract is announced next spring to find out, because in the meantime, that uncertainty means practices could struggle to bring in new partners. It could add to uncertainty about whether or not they've got the money they need to hire staff. And as some people have warned, it could lead to some practices deciding they'll just hand their contracts back. So urgent reassurance from the government is vital. I think that's the key message that's come out of the responses we've had from a variety of organisations.
There's a couple of other things that are also worth highlighting, actually things that weren't in the budget that people were expecting. So there was no changes to pension tax. There'd been real concerns that the government could reintroduce the lifetime allowance limit, which could potentially have caused problems for some doctors in the NHS pension scheme. So that didn't happen. In a bit of a surprise move, the Chancellor also said the government wouldn't extend the freeze on tax thresholds past 2028. It had been predicted that she would freeze those thresholds again, but from April 2028 they will rise in line with inflation, which means that less people will be dragged into higher tax brackets as wages rise. Another thing that was actually quite interesting that I spotted, there's a new white paper coming called Get Britain Working in the coming weeks that's going to sort of cut across the health, education and welfare departments. And as part of this, the government says it's going to look to establish 8 trailblazer areas to look at improving the support for people who are not working due to ill health and helping them return to work. So we'll have to wait on that white paper to see what exactly that might mean. And there are also going to be reforms to health and disability benefits early next year, but also not entirely sure what they mean yet either. But all in all, there is a lot to digest in the budget and a lot of things, as you say, Nick, that GP practices are going to be very concerned about unless the government can provide some sort of assurance on how those extra costs will be funded somehow. Well, that's it for this week. Thanks to Nick and Kimberley, and thanks so much for listening. I'll be back next week when I'm speaking to GP and Director of Research and Policy at the Nuffield Trust think tank, Dr. Bex Fisher, about how we can make general practice funding fairer, her career in policy work and her views on some of the government's plans for primary care. So please do join me then. In the meantime, don't forget you can keep up to date with all the latest news affecting general practice on our website at GPonline.com.